Kenyatta University Teaching, Referral and Research Hospital is a modern tertiary health facility with state-of-the-art services that ensure delivery of cutting-edge healthcare and medical research in Kenya and the region.
Hi everyone, my name is Dr. Andrew Wewe. I'm a board-certified plastic and reconstructive surgeon working at Kenyatta University, teaching, referral and research hospital. We provide a range of plastic and reconstructive services. These range from wound care management, burn management, skin grafting, reconstructive flaps where we have defects, maybe involved in a road traffic accident, to supporting the other clinical specialties in terms of the plastic surgery needs that they do. Once we get a cancer diagnosis for most of our patients, then some of them have to undergo chemotherapy, radiotherapy, especially after they have undergone the reconstructive surgeries. So you find that we have nipple sparing mastectomy, we have skin sparing mastectomy, and basically this is where we cut out the tumor. So what we are doing now in this institution is we are giving patients a choice that after they have removed the tumor, then you can be able to reconstruct your breast back to the form in which it was. So here at Kenyatta University Teaching, Referral and Research Hospital, from the 19th to 23rd of February, we are going to have 5 world-renowned surgeons coming from Harvard Medical School, coming from the Canadian Society of Plastic Surgery in Argentina. The main objective of the workshop is to facilitate exchange of knowledge and skills between the medical staff in our institution and the visiting surgeons. This will contribute to improvement of the service and the quality of service that you're able to provide in this institution, and hence better care for our patients. So the main highlights of this particular workshop will be having interactive sessions with the visiting faculty. We'll be having live demonstration of our cases in our theaters here, where you'll be able to watch and see their innovations and techniques. We'll also be having hands-on workshop, including case studies and panel discussions for the difficult cases and how to go about it. We are going to see more than 30 patients, attend to more than 30 patients here at our theaters. Our target audience will be around 30 to 60 plastic and reconstructive surgeon residents, breast oncologists and breast surgeons. So the benefits of this workshop will be able to have transfer of knowledge and skills, have innovative techniques that we are going to apply in terms of management of our patients. And further to that, then it will also help us in terms of our networking with this international faculty and spur research, which is one of the core functions of this institution, so that we can better manage and provide better quality for our patients.
Allow me to start by welcoming all our guests to Kenyatta University Teaching, Referral Research Hospital and to this important workshop. To our international guests, karibuni sana. I will mention a symbolic patient. Let me give her a name called Halima. Halima. Halima stands before us as a symbol of strength. Diagnosed with breast cancer, she fought a valiant battle, emerging victorious. Yet a constant reminder lingers: avoid where her breast once was. Halima's story sadly echoes in the countless Kenyan women who navigate fragmented care, leaving them incomplete even when treatment comes to an end. I'm glad that at KUTRRH today, we are writing a different narrative through this breast reconstructive workshop. This workshop is a pledge to a complete continuum of care for breast care patients. I'm delighted that this initiative is aimed to achieve this paramount goal, restoring dignity to our sisters, to our mothers. Since its inception in August 2021, over 3,600 patients like Halima have sought not just diagnosis, but understanding, comfort, and a path to a wholeness at KUTRRH Comprehensive Breast Care Center. In 2023, the center realized an outstanding 440% increase in patients, an indication on the trust placed in our expertise at KUTRRH and our commitment to accessible, quality patient-centered care. We have seen a steady increase in patients across all age groups, denoting that no woman is left behind. Today, the most common diagnosis at the CBC is cancer of the breast. While treatment plays a vital role, reconstruction is more than just aesthetics. It is the final chapter in the healing journey, a path to reclaiming wholeness and confidence. In the last 2 years, we have performed over 150 surgeries. This has offered hope and restoration for these women. It is delighting to note that this workshop empowers our skilled surgeons in Kenya with the latest techniques. With the help of the visiting faculty, we can build on this momentum. I have no doubt that our working together will ensure that every woman in Kenya has access to early detection, quality treatment, and comprehensive care, including reconstruction.
This hospital is 4 years old, and I'm happy and honored to say that it was my vision when I was the Vice Chancellor of Kenyatta University. We built it when I was a VC there, and then I left the institution and went to do other things, and then about 3 years later, I was called back to come and complete the vision that we had as a chairman of the board. So I'm very familiar with this hospital, and I'm happy to say when our president came to visit this hospital a few months ago, he approved the construction of that breast care center. And this breast care center, even now, and when we build it, the bigger one, it's going to be comprehensive. We are going to have specialized expertise. We are going to also encourage women to go for screening so that if they are sick, then can be detected early to increase the chances of survival. And also be a center where we can educate women. We only have one women hospital in Kenya, and we propose another one. Again, it was approved by the government. It's just now looking for money, and we have the drawings. We are ready to take off. So in Africa, there are few, and the ones available in Kenya are private hospitals. What we want is to start a public one, because a lot of people come to public institutions because it's cheaper, and provide what we said about advocacy so that the national insurance can cover some of these services. I think some of us at our level now, maybe we can support that in terms of convincing the government that they need to cover this. So that is really our dream, and we really want to commit ourselves to do whatever it can to improve the health of not just Kenyans but also the regional citizens who are coming a lot. We are serving patients from 15 countries. We are actually regional, and we feel that we can transform the landscape of breast reconstruction care to ensure that every individual facing the breast cancer has the opportunity to thrive and not just to survive the disease. With those few remarks, I would like to declare this symposium officially open. But from the statistics, it shows that most of the patients who are coming, they are presenting stage 3 and stage 4 cancers. And we feel that is really very sad. I hope in a few years or even sooner, we can turn around these statistics so that maybe the majority are seen at stage 1 or 2, or hopefully not even no cancer. But that needs a lot of screening, early screening, a lot of education, a lot of talking to people so that they can go for tests. And we want what is happening in the advanced countries where the majority of women survive the disease because it's seen early, through their normal annual checkups, because then you save a lot of money. Because then if it's seen early, then you are treated, it's cheaper for the government. Instead of waiting until you are stage 4, the survival chances are lower, and it's also very expensive to treat the disease.
In terms of the diagnosis of breast cancer, I think we are okay. The treatment options are available, but like you have heard that we have concerns regarding the untimely presentation of patients, that most of our patients present in the later stages. So that's obviously a challenge. We also have younger patients who present with breast cancer. So that's also a challenge. Then if the only option that we can offer these young patients who present late with breast cancer is a mastectomy, then of course we can see one of the challenges that we'll get is that they will not present or we make the diagnosis and then they disappear. So some of these collaborations that we are doing and some of these symposiums that we are doing to show that there are options of treatment, they will probably improve in terms of our outcome and how patients present.
Thank you. I'm Dr. Andrea Pusick. I am professor of surgery at Harvard Medical School and chief of reconstructive surgery at Brigham and Women's Hospital in Boston. I think Kenya is at the beginning of its journey. I think that the needs of women, the fact that we're highlighting that, they're at the beginning of that road. There is definitely the technical knowledge. There are incredibly skilled surgeons here, but I think the combination of bringing together the multidisciplinary teams, the resources, the leadership support, the government support to be able to provide access. All the pieces are here. Everything is here, but to your point, I think they are not. I think this is just the beginning of a journey to be able to provide the best care to breast cancer patients. I would also say that the issue around women presenting quite late with breast cancer, I think one factor is that when they know that there is no access to breast reconstruction, a woman may stay at home knowing that she has a breast cancer because she fears mastectomy. So I think there's also potential to make it that young women may present earlier with their breast cancers, knowing that mastectomy is not the end. So congratulations on the efforts of this amazing team.
And sometimes improve because the pressure of the vein. Some component of the lymphedema is water. It's not lymphatic. Yes, because a lot of times the patients don't imagine where they are going. And for one fat grafting, the result is in the middle. So the patient come again for the nipple. It's very important. So you take advantage of the nipple to the lipofilling. So in that way, you can have better results. So Sarah,
so you see how
Sarah is a great person from here. Because Sarah, and because all of the people from here, the hospital, this dreaming is possible. This is autologous reconstruction using the own tissue for the patient. We are not using expanders or implant because the patients have a bilateral defect. So we are doing a delayed reconstruction in the right breast and immediate reconstruction in the left breast. This is immediate because today the mastologists, the oncologists are doing the mastectomy. So this is the two different types of reconstruction of patients. Patients have a mastectomy, no reconstruction, so the patients make a consultation in a future for a delayed reconstruction. And when the patient have resources, can access to the medical center, there is economic resources, insurance resources. You have doctors. In the same moment where they are doing the mastectomy, you can start the process of the reconstructions, doing an immediate reconstruction. This is the two times, delay and immediate.
The one that put a current on the other side, yeah. This is just checking.
Lymphedema is water. It's not lymphatic, it's water. So we release the veins.
My name is Dr. Sarah Nyakiongora. I'm a plastic surgeon here at KUTRRH. So today what we are doing is breast reconstruction for breast cancer patients. So basically patients who've had their breasts taken out due to breast cancer. We are restoring the breast mound by using tissues on various parts of the body. So like for instance, the case that we just finished, we used tissues from the abdomen or from the lower part of the abdomen to reconstruct a breast. And then the case that is just coming up is a patient who also has breast cancer. We are going to do the mastectomy, which is removing the diseased breast tissue, and this time we're going to use tissues from the back to recreate that breast mount. The patient that we have coming up next is a 50-year-old female patient. She was diagnosed in June of 2023 with stage 2 disease. She's undergone chemotherapy, about 8 cycles that she completed in December. And so now she's come for the mastectomy, which is removing the diseased breast tissue and to reconstruct with a flap or tissues from the back. I'll be one of the surgeons who will be operating, but I'll be assisting one of my mentors called Dr. Anita Kendi, who is a professor of plastic surgery at Harvard Medical School. Then we also have Dr. Marek, who's a breast surgeon from Aga Khan University Hospital. He's the one who will be carrying out the mastectomy. We usually work with the breast surgeons. So he'll do the mastectomy, then we will do the reconstruction.
Do something like this even, but you can do it by degrees. You start with one thing, and then you do the next, and then the next, right? So you don't have to commit to doing the whole thing once. If she had more ptosis, it was a bigger breast, I wouldn't do it this way. I'd probably do a proper either Y pattern or vertical and bring it and really get that. But here we're just trying to keep her as similar as possible. We're not trying to make, we just want to replace like with like. And we know that we're probably going to get a little bit of like here. I do think though if her breast was actually matches perfect without it, then maybe we won't do the lift. Does that sound, or would you prefer the lift? I think that particularly with the women who come to us and they're having the breast cancer with reconstruction, if they were always happy with their breast, we shouldn't necessarily be trying to turn it into a cosmetic operation. It's a lovely woman who's in her mid-50s. She has a left-sided breast cancer. The breast cancer is such that the nipple and the areola area need to be removed. And the breast surgeon's also going to check her lymph nodes, which hopefully there won't be any cancer there. Then we are going to do reconstruction of her breast by taking some skin and fat from the back and bringing it around to the front effectively. So that's called a latissimus dorsi flap. And so that will essentially replace the breast. All the skin will be kept except for the nipple and the areola. And then the skin and the fat from the back will be brought around to replace the breast tissue that has been removed for the mastectomy so that it will still match the other breast. We'll see. And the main thing also is we're operating with these really skilled young surgeons who are keen to improve their skills in doing this technique so that they can offer that kind of surgery to women here in Kenya. So it is a common procedure. I will say though that breast reconstruction in general in Kenya is not very common, and that's something that we're hoping to change, that women would have access to breast reconstruction. So while it's an operation it's a tried and true operation, it's been done in a lot of settings for different reasons actually, other than just breast reconstruction. We're doing a few of the same procedure. My colleagues are doing it in another room as well for a different patient. And the idea is that we can teach this procedure and then it can be offered to many, many women here having surgery that are presenting for breast cancer care.
She discussed it with the team before, so that's why we are doing skin sparing, mastectomy, but we are removing. At the same time, the other reason we are removing the nipple is because then we have the skin flap from the back, so we can monitor the flow. So it's from oncological point of view, and it's also from aesthetic plastic point of view. We can monitor the flow, see what's going on. So my name is Marek. Everybody here in Kenya knows me as Dr. Marek. Breast cancer is the most common cancer in the world and is also the most common cancer in Kenya. Breast cancer does happen, and 1 in 7 ladies in Kenya will have breast cancer. 40%, almost half of breast cancer happens to very young ladies in their 30s and early 40s. And this is the message which we need to send, because it doesn't happen only to old ladies. This lady today will have mastectomy with sentinel node. We have to assess the lymph nodes, if the cancer spread to lymph nodes or not. And she will also have immediate reconstruction. She will wake up with a new breast. These days, we can offer breast conservation, we can keep the breast, or we can rebuild the breast immediately after the operation. And this is exactly what will happen now.
I was suffering from gigantomastia. Gigantomastia is the abnormal growth of the breast. Ile kitu ilifanya nikakubali kukuja hospitali, it's because I was undergoing through a lot of stigma. Na kukuwa na matiti kubwa ukiwa mdogo, kuna mtoto, people were really talking bad about me, watu walikuwa wananiongea. And so hiyo ndio kitu ilifanya nikakubali kukuja hospitali kufanywa surgery ndio matiti yangu kubwa. Initially nilikuwa na matiti kubwa but si kubwa sana. So when 23 nilipata job ndio matiti ilianza kumea, and I assumed ni kwa sababu niko na pesa, ni kwa sababu hakuna mateso napitia, niko na starehe. So nika-assume again mimi ni wa single mother and I don't know my father. My parents, mamangu akubali indisclose at the side of my father. I don't know my father. So mimi I thought the side of my father wanakaa hivyo. So I kept quiet. And when my grandmother saw me, ndio akaniambia this is not normal and there is no one else in our family anakaa venye ninakaa. Hapa ninakaa ni kama niko na shimo because of the bra. So the breasts were very heavy. Sasa nilikuwa natokea shimo kwa sababu ya hiyo kuvuruta. Again the breasts zilikuwa zinanivuruta mbele. Nilikuwa nakaa hivi before. I could not sit upright like this. Singeweza kufua nguo kwa sababu nikiinama hivi ninaanguka kwa sababu matiti ni mzito. So I could not bend. So mimi nilikuwa hii mwaka nimekuwa na bra moja. Nilikuwa naivaa kila siku Monday to Friday, nikiwa kazi inafuliwa Saturday, Sunday nashinda kwa nyumba, Monday tena navaa. Ikiwa inanuka tu sweat hivyo kwa sababu singeweza kutembea bila bra. Matiti zimejivuruta, ni uchungu, siwezi kaa bila bra. Nimesafa. Sijui fikiria nitaifanywa surgery. Again nilikuwa najiona niko mdogo sana. So myself nilikuwa najiambia sitatoka kwa theater. Nilikuwa naogopa sana. At first when niliuliza Dr. Moki about the surgery, ile kitu yenye after surgery what will happen, he told me it's 50-50 to breastfeed. And now I felt nilisikia vibaya sana. Mimi nikamwambia basi kama sitaweza kunyonyesha watoto wangu, I don't want, wacha tu ikae. And he started talking with me, akaniongelesha, akaniambia siku hizi si lazima ninyonyeshe mtoto, kuna formula milk, kuna watu pia wako na matiti mzuri but haiwezi toa maziwa. And that's how I came to accept myself na nikakubali, though I was very scared. When niliamka hivyo tu nilisikia kitu imeanguka na mbele. Niambia daktari, kuna kitu imeniangukia kwa matiti. Sasa Dr. Kim. Sasa hapo ndipo nilikumbuka nilikuwa nafanywa surgery. Nikaanza kushika matiti, akanikataza, akanifungulia. Ndio imekuwa ndogo, lakini nilifurahia. I really shouted. Na sasa ndio nikaambia huyo surgeon ninataka kuongea. I will talk on behalf of the voiceless people, hawa watu wenye wako community, hawa wasichana wenye wako vijijini, wako na matiti kubwa but they don't know what they can do. What I knew kuna surgery ya cancer peke yake na kuna surgery ya growth, breast growth, ukiwa na kitu kwa ndani. But sikuwa najua matiti kubwa inaweza katwa irudishwe ikuwe kidogo. So I knew there is someone in the village somewhere or in the community or even in the towns mwenye amekaa hajui kama matiti inaweza reduciwa. So my story, my main other aim ya kuongea, nataka history yangu izunguke ifikie kila mtu, at least hao wenye wako na matiti kubwa na hawajui kama wanaweza fanywa surgery. Nataka hiyo message wafikie, at least wataweza kusaidika. Nikamwambia mimi najua surgery ya matiti hukost pesa mingi sana. So mimi nikamwambia mimi I won't afford. Akaniambia NHIF can pay for you. And because I'm employed na NHIF yangu imekuwa ikilipo kwa kazi, so my NHIF iko active. So after 48 hours waka approve 120,000. Na hivyo tu ndivyo nimekuja hospitali. Hospitali sijakuja na kitu, sijakuja na basin, sijakuja na slippers, tu nimekuja na nguo zangu zenye nilikuwa nimevaa. Nikalazwa. Hakuna kitu nimelipa yote kwa hospitali. Hakuna sofa kitu nimelipa. Mwenyewe hata siamini ni mimi. I'm still feeling as if I'm dreaming. Mimi siamini, akisiamini. Naona ni kama ni uongo.